Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important, so we want to answer them as many as we can, so that's why we're doing this. Jim, let's go right into this. Brookings, 63-year-old person, 27-year-old daughter, has rheumatoid, is treated with biologic medication. She wants to have a family. Will they keep her from having a pregnancy?
No. If it's biologic alone, okay,
right.
If she's just on a biologic without methotrexate, shouldn't be a problem. It should be okay. Okay, I mean every indication right now is that it's okay.
Wow. 80-year-old Parkman, Wyoming. I have severe osteoarthritis and get injections 3 times a year in the hip. Would it be safe to increase the number of injections? Good question.
Well, I presume they're getting steroid injections.
Yeah.
Okay, and in weight-bearing joints, about 2 and at most 3 times a year is all you want, because that, if you get too much steroid in there over too long a period of time, can make it break down a little bit faster. So I would stick with, I wouldn't do it any more than 3 times a year for sure.
All right. Let's see, diclofenac.
Yes,
ulcers
right, Voltaren.
Voltaren, diclofenac, ulcers in the stomach, intestines. What is a better alternative treatment?
Well, again, non-steroidal anti-inflammatories are, you have that same potential problem with all of them, but just because you have a problem with one doesn't mean you're going to have a problem with another.
Celebrex is a big one that people use.
Celebrex would be, if I had somebody that had ulcers with a traditional NSAID and I still wanted to use an NSAID, I probably would use Celebrex. It has a little less GI irritation than the other ones. But in general, you got to be careful with any of them.
Any of them. So probably get off of that, try something
else.
else.
I wouldn't take that one anymore.
Well, that's for sure.
There's 26 other ones you can try if you had to.
Okay. Daughter has rheumatoid arthritis and GI issues. Is there a correlation? Also, how can she manage her symptoms? So GI.
So, there's what's called enteropathic arthritis, which means that people that have certain inflammatory bowel diseases, like Crohn's disease, ulcerative colitis, can also have an associated arthritis. And so when we have somebody who has what looks like rheumatoid or could be a variation of rheumatoid, and they also have bowel issues, it's very important to get the bowel thing worked up, because they may have something that is related there, the inflammatory bowel thing. By the same token, a lot of people with rheumatoid arthritis, because of the meds we use, get GI issues.
Yeah.
And so you got to be, if you had somebody who was taking, say, a couple thousand milligrams of ibuprofen a day, plus methotrexate once a week, plus hydroxychloroquine,
it's amazing
plus
your
some
gut isn't
analgesic, you would expect that you might have some GI things.
But people who have Crohn's disease or ulcerative colitis sometimes are treated with the biologic medicines that are used for rheumatoid arthritis.
Yeah, then you got a twofer, okay?
Twofer.
Yeah,
okay.
2 for 1.
Yeah. 68-year-old from Viborg, patient rheumatoid arthritis for 8 years. Is there a diet for this patient?
With rheumatoid arthritis?
Yeah, rheumatoid arthritis, is there a diet you would recommend? Not really. Doesn't matter.
No.
Not an issue.
It's, there's no, it's like I was telling you during the course of the program. I mean, if there's something that seems to set you off as far as your arthritis is concerned,
Avoid
then,
that.
I mean, if you have a bad day with your arthritis, you got to think about what you ate the day before. If you ate something unusual the day before, then test it again, okay? If I ate shrimp, okay?
Right.
And now I'm just have a terrible day, in a week or so, eat some shrimp again. And if you have a terrible day, guess what? You just found that you may have a shellfish something or other that's setting off this immunologic thing.
Wow. And
it may be very subtle. So that's unique to you. But we can't go to the whole world and say, don't eat shellfish if you've got rheumatoid arthritis.
Right. There you go. 72-year-old Clear Lake patient. How does psoriatic arthritis compare to rheumatoid? Psoriatic versus rheumatoid arthritis.
Well, I don't mean to make this more complicated than this, but just for starters, there's 5 different kinds of psoriatic arthritis.
Okay. It is just. So is it an immune system where your body takes off against your?
The plaque psoriasis is an autoimmune.
Right.
Thing. Okay. All right. But there are all kinds of variations that can affect the joints. You can have 2 autoimmune things, rheumatoid arthritis and psoriasis in one person. Okay, and that's just 2 relatively common diseases that showed up in the same person. You can have a plaque psoriasis and what looks like rheumatoid, but serologically the blood tests are all negative. That's another form of it. You can have psoriasis, and then you have what we call oligoarticular arthritis, where it's a wrist and it's a knee and it's an ankle, 3 joints or 4 joints. That's a form. Then there's another form where it tends to hit these joints, which rheumatoid never does, okay? And so you can get inflammation and destruction in some of those outside joints, the DIP joints. And then there's a very mutilating form, which I have personally never seen. It's so rare, I have never seen it.
What is it called?
It's called arthritis mutilans, psoriatic arthritis mutilans. I've never seen it.
Okay.
I've seen pictures of it, but I've never seen it.
I'm glad, and I hope you never see it.
I hope, well, and chances are it probably won't.
Caller. Caller has shoulder arthritis with fluid buildup that needs draining. How can they stop the fluid that builds up in the joint?
You got to figure out why it's
building up.
building up. Because if you just take it out and you don't do anything, it'll come right back.
How about injecting a steroid in it?
Yeah, but if it comes back, then you still got something, you need to control the disease. If it's rheumatoid causing the effusions, you got to control the rheumatoid disease or they'll just keep coming back.
All right. 56-year-old woman with MS and 3 different kinds of arthritis, currently in an MS hug right now. What can you do about it? MS hug. Do you know what that is? I don't either. How about MS and other kinds of arthritis? Do you have any knowledge?
No, MS is probably some kind of
immune
autoimmune or immunologic mediated thing, but
it attacks different spots in the brain in different periods of time.
Yeah, but there's no really real relationship. Now, I've had people who have had MS who develop rheumatoid arthritis, but that's just, again,
2 different diseases.
Okay.
How about biologics that you would treat the rheumatologic disease? Does it help MS?
In fact, it's even worse than that. Sometimes we have to be careful when we're using the biologics because we can provoke MS-like reactions in people. So a side effect, unusual, very unusual. I can maybe 2 or 3 times I've seen this in 15 years now of using biologics, where I've provoked an MS-like reaction where I stop the medicine and those neurologic symptoms go away.
So they advertise those biologics on TV. For example, you've seen the Humira and Enbrel
right.
and that kind of a thing. Do you feel that that's responsible? That people would say, I want to have this, doctor, and the doctor would give it? Or what's your take on all of that advertising?
No, the thing is that first of all, let's go back to the beginning. You need to make a prompt diagnosis of rheumatoid arthritis, okay? And I think the rheumatologist, more than anybody, can size things up in terms of what are we dealing with here. What's the prognosis going to be for this patient? We have disease activity indicators that we can use lab-wise, joint count-wise,
right.
patient digital scale-wise, that they can tell us how much pain they're having, those kinds of things. And we can come up with an idea of this is going to be really aggressive disease, or maybe this isn't going to be such aggressive disease. And then you start a plan at that point. If it looks like it's going to be really aggressive disease, I'll have them on methotrexate right away, okay? Right away. And if that methotrexate isn't turning them around and making them functionally almost normal in 3 to 4 months or so, I'll be very quick to add an Enbrel, Humira, something like that.
But this should not be something the patient encourages the doctor to do and the doctor will do it. It should be without influence by the patient's advertisement.
Direct consumer advertising to me is a double-edged sword, okay? I encourage people to learn about medicine and to learn about health and to come and ask me questions. And if that commercial makes you come and ask me about Xeljanz,
right.
Okay, great. We'll talk about Xeljanz. That stimulated that. If that commercial makes you demand that I give you Xeljanz when I don't think that's the right thing, then it's doing a disservice.
Right. 55-year-old male, Scleroderma, 4 years. Any closer to finding a cure for Scleroderma? Current drugs weakening the immune system. Well, I mean, Scleroderma, tell quickly what it is.
Scleroderma is a disease that Scleroderma, literally translated from Latin, is hard skin. Okay.
And that's what it is.
And it basically is a replacement of normal collagen and subcutaneous tissue with fibrous tissue, and so
Scar
you end
tissue.
up, and then it can get into the lungs and it can get into the kidneys and all those kinds of things. And unfortunately, it's not the classic autoimmune like lupus or rheumatoid where you have this inflammation that you can control with these different drugs. You have this sort of fibrotic tissue replacement process going.
Has nothing to do with fibromyalgia.
No, absolutely nothing to do with that. But here's the thing with, first of all, there's a lot of research in scleroderma going on right now. Okay, so there are at least some flickers on the horizon of things that might be helpful going forward. Secondly, very often what can look like, oh my gosh, this is scleroderma and this is going to be a downhill glide path, all of a sudden flattens out and it doesn't progress.
Right.
I've seen people who I thought, oh my goodness, you know, we've got all this scleroderma going on, and then all of a sudden it kind of stabilized, and yeah, they ended up with some Rainouts, some cold sensitivity, and some hard skin, but they never got the other things. Yeah. And so, you know, it's not one of those things where you wring your hand and say, okay, I'm going over the bridge, okay? Yeah. It may stabilize, okay? And
okay, so there's hope.
There is hope.
Dupuytren's contracture in hands, how can you care for this, and when can I receive care? This is a person with rheumatoid arthritis, but it doesn't have to be rheumatoid arthritis.
No, in fact, most people who have Dupuytren's contracture don't have
not have rheumatoid arthritis.
In fact, it's mostly hereditary. And it's just a contraction that you get down in the tissue there. You see
and
that?
It brings this down and this one, right? You have a little bit.
I'm getting a little bit of one.
Yeah.
So it brings it down like this. It wants to bring it down. And what you do is you keep resisting that, okay? And it stretches it out and stretches it out. And if you keep stretching it out, now if it can't be stretched out, there is a little surgical procedure they can go in and take it, but it tends to scar down again. And so it's better just to.
But it isn't the tendons that open and close your hand. It's the fibrous tissue
alongside the tendon.
Yeah. So you know you can fix it again. Rainouts.
Yeah. Cold sensitivity. So Rainouts is an overreactivity to cold, and so if you think about this is a blood vessel, okay?
Right.
This is your skin. And you go outside in the Brookings of winter.
Yeah.
Okay. And it's cold.
And it's cold.
And that blood vessel, your body says, "Oh my gosh, we got to conserve heat." And what's it do? It squeezes down like this.
Tightens up.
It tightens up, and so it forces that blood to stay where it's nice and warm on the inside here, not out here.
Right.
Okay. What happens in Rainouts is it tightens up, but it forgets to let go. So when you do it, it tightens up, and then you put your gloves on and your mittens on and everything, and then it kind of relaxes. Says, okay, we can handle this.
Yeah.
Okay. With Rainouts, it overreacts, and so you end up choking off the circulation to the fingers, and you get white fingers, and then after a while they get really kind of dusky looking because there's no good blood flow there, and then suddenly it'll open up and it'll get bright red and it'll sting, and that triphasic white, blue, red is classic Rainouts, and you can have variations on that theme, but that is seen in people that have inflammation going on in their joints and their hands more often. And so with all of the arthritic connective tissue autoimmune diseases that we have that have small joint inflammation, they tend to be cold sensitive and have a little bit of Rainouts.
Right. But you could have just Rainouts without rheumatoid
just
arthritis.
Rainouts, right. And it can come and go, and it can come and stay.
Okay. Here's one on polymyalgia rheumatica. We just talked about that. What can I do about hand, foot, and leg cramps?
Stretch.
Yeah.
Make sure you don't, keep your electrolytes in balance, and then there's a bunch of home remedies.
Right. My answer to that one is that it commonly is because the fluid goes in and then it goes out, or it goes out and then it goes in. I mean, it's a fluid change. People who have edema in their legs get the support hose.
Right. I use, classically, I mean, this is partly urban legend, okay,
right.
Partly myth, okay, but I'm going to tell you anyway. But
okay. But tell me anyway.
Quinine pills.
Right.
For cramps.
Yeah.
Right.
Right.
So right now you can't buy quinine pills because they did one of those funny drug things, made them really expensive or whatever, and you can't get it. But you can get quinine, and it's called tonic water.
So a little bit of gin and tonic.
No,
you don't need to have
the gin out. Just leave the gin out. Just take a little juice glass of tonic water when you go to bed at night. Sometimes it'll
help you a little bit.
Make the medicine go down.
Yeah. Are infusion therapies more harmful than injections for long-term use? Do you know what they're talking about?
Yeah, well, like Remicades an infusion, Rituxan's an infusion, Actemra's an infusion.
Yeah.
Humira, Enbrel, Simponi, Cimzia, those are injections. it really is, there really is nothing that would make one more, it's...
How do you pick your, because I haven't learned the direction on those. Do you always start with Enbrel? Do you always move on to this or that? Or did the
part of it is, Enbrel was the first one, first one out there. Okay, so Enbrel, then Remicade, then Humira. They were the first ones out there, so that's what we have the most experience with.
Right.
And I always liked the nature of Enbrel being a relatively short act. I was nervous to begin with.
Right.
I'm going to give you something that you got to take every 3 or 4 days, but if I start having problems, guess what? In 3 or 4 days, I can have you away from it.
Yeah.
If I give you something that you get every 2 months, I got to deal with this for the next 2 months if you get an infection or something like that.
Yeah.
So theoretically, I like the shorter acting ones, and so I got a lot of experience with Enbrel and Humira. But then there's times when I really want to be able to control the process, and Remicade is a much better choice because I can really fine-tune that process.
Right.
And so that's,
Through the years, that's where you've come.
it's an experience thing.
One final word about fibromyalgia. No one believes how much pain it can cause. She's kind of desperate. What would you call fibromyalgia, and what is your help?
Well,
for these people?
fibromyalgia, I mean, it's a pain syndrome. It is the things that we know about it is that there's an overactivity in the pain fibers, in the nerves,
right,
in the pain fibers.
Yeah.
Okay, so it first of all, makes you more sensitive to touch.
Right.
You can get tender areas and places which would normally be tender if I pushed hard enough.
Right.
I don't have to push very hard and they're tender. Okay, and so that's how this tender point business came along.
Right.
And it's like you've got this hyped up pain nerve system in your body. Now we don't know why that is. It's not autoimmune. I can give you prednisone. I can give you what. I mean, it doesn't have nothing. But there are some medications out there that will slow those pain fibers down a little bit. Things like amitriptyline, the old tricyclic antidepressant, and some of the derivatives, some of those medicines, gabapentin, Neurontin, Lyrica, one of the newer ones, sort of son of gabapentin.
Yeah, son of gabapentin.
Yeah. That will slow that down and help that. The other thing is that rest, good rest, is very helpful. So that back in the days when I used to treat fibromyalgia, I would use things that would help, not sleeping pills, but I would use things like amitriptyline or cyclobenzaprine or nortriptyline or something at night to try to people rest. And then we would start a very gradual, graded exercise program. Yeah. The worst thing you can do is to say, go exercise, because you'll overdo it and you'll feel terrible. But if you go and you just start really, really gradually, just a low grade, I tell people to start embarrassingly little. Okay, in other words, I put my swimming suit on and I stuck my toe in the water, and then I put my clothes back on and I went about my business. That's the first week, okay?
Yeah.
Then I stuck my whole foot in
That's gradual.
I'm exaggerating,
right.
But it doesn't matter whether it's walking or bicycling or whatever. You walk around the track once and then that's it. And then tomorrow you walk around the track once and that's it. And then next week you walk around the twice 1.5 times. And the weekend, there's no race here, okay? You've got the rest of your life.
Right.
Okay, go slow. And the more exercise tolerance you get, so if you can rest at night, you can get the exercise tolerance up, you can use some judicious analgesics, not narcotics.
Right.
Okay?
Avoid the narcotics with that one.
You can control it to the point where you can live reasonably sanely, okay?
Yeah.
And not be going crazy with pain all the time.
And stay in touch with your doctor, because there might be something else that would raise its ugly head eventually. Yeah. Well, Jim, thank you very much for being with us. Yeah. This has been great fun and very learning for me, as always. Thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. Until next time, stay healthy out there, people.